Good afternoon. My name is Yuqing Yang. I am the director of the Statistical Unit here at the UCLA Center for Health Policy Research. Welcome to today's online seminar, Combining Traditional Modeling with Machine Learning for Predicting COVID-19. I'm thrilled to introduce our special guest today, Christina Ramirez, a professor of biostatistics at the UCLA Fielding School of Public Health. Dr. Ramirez and her esteemed colleagues has been working tirelessly to predict and track COVID-19 case and death rate using a unique combination of models. Globally, there are more than 13 million confirmed COVID-19 cases and a death toll of more than 580,000. With the recent and alarming surge in COVID-19 cases across the US, which we are now counting at almost 3.5 million confirmed cases and 138,000 lives lost. The roles of public health research and the partner are even more crucial in slowing down and ultimately stopping the spread of the virus. The recent surge called for more effort to prevent overburdening the healthcare system and upholding the public health mission to protect vulnerable populations. As states making decisions about reopen, they even present an increasing health danger, prompt an even greater need to understand the disease and its spread among the communities in not only the state of California, but throughout the nation. With healthcare experts using various models to help forecast case and death rate, to ultimately identify hotspots and the need for targeting resources in those areas. While most use either compartmental SEIR models, curve fitting, or machine learning to model COVID's case and death, Dr. Ramirez and her colleague have combined all three techniques into a single model. In this talk, she will share her groundbreaking comprehensive model that combines traditional SEIR models with case variety and machine learning to get precise, reliable estimate of COVID-19 case and death rate, shining a light on whether the pandemic is gaining speed and if the deaths are accelerating or stabilizing. This project also used the CHIS data from the UCLA Center for Health Policy Research to obtain an accurate snapshot of California's data, so that the mobility and mortality rate are based on the non-preference of the social demographic factors, such as age, race, ethnicity, and the comorbidity or underlying health conditions. Dr. Ramirez and her team were also among a group of scientists who work with lawmakers in Los Angeles, California, London, and even South Africa to enact masks as a source control prior to the CDC and WHO recommendations. If you are interested in today's slides, you can request them from our communication department at the email address shown on your screen. Please stay tuned for announcement on our upcoming seminar in August on work we are doing around COVID-19 in the native Hawaiian and Pacific Islander community with a spectacular group of graduate students from across the country. Now, let's begin today's discussion with Dr. Ramirez.
Hi, thank you for inviting me. It's a pleasure to be here. So this work was done with the help of graduate students, especially, I really want to give a shout out to Greg Watson, who works at the Center for Health Policy Research. He is phenomenal. As all of these graduate students, at the very beginning of March, I sent, probably March 1st, I sent out an email to graduate students who would be interested in working with me on these models. And Greg Watson, Di Zhang, Lu Zhang, Jay Zhu, Joseph Zoller, Philip Sundin, Jan Shipshelin, and Teresa Bufford came to my office. And at the beginning, we were working 12 to 20 hours a day to get this model, also with the help of Anne Ramoyne and Mark Souchard over here in UCLA. So thank you for joining me. This is not going to be a technical talk. So I think there's only one slide with the equation, so don't worry, I will explain all of this. And so I'm pleased to talk about what we've done for modeling COVID-19. So we've already talked about the devastating toll that COVID has taken globally, but we really need accurate estimation of cases and mortality projections to be able to make good recommendation for decision makers. So as Yu-Ching was saying, there's three main types of models that are used for COVID prediction, and we'll talk about each of them in order. So the most common ones are these epidemiologic compartmental models. And then, so this was the very first Imperial London model, was a traditional SEIR model. Curve fitting models, the very first one that you probably heard of was the IHME. When they first came out, these were curve fitting models. And lately we have machine learning models. And I study machine learning, so it's near and dear to my heart. And so we actually combined all three of these into our models. So first, let's talk about what these compartmental models are. So ours specifically is a SEIRed model. And so you probably hear SEIR, SEIR, SEIRed. So it's really sort of simple. And so you envision the world in 4 different compartments. So susceptible, so people who are susceptible to infection. And because this is a novel virus, we assume that everybody is susceptible. And susceptibles transition to infected. And infected, you can either recover or sadly, you can die. And so we have each of these 4 compartments, and we model through a system of differential equations the transition probabilities for each of these compartments. Oops, sorry. Okay, so this is the most common model. It's been used for over 100 years to describe disease phenomenon. And so we have this system of differential equations, and we can use the literature, we can use prior information, or we can derive parameter values empirically from the data to govern how people transition from each of these compartments. And these solutions to this differential equations allow for easy joint modeling of the disease states. So we can put recovery, we can put hospitalizations, and other states can naturally be incorporated into these separate compartments, which is why they're so widespread. And they also allow for projections forward. So curve fitting, the projections are usually really, they can't go that far because you have to project a curve along. These SEIR models allow for much longer projections. But disease transmission rates have changed due to political, societal responses, these lockdowns, these mask ordinances. And so modelers have to model upward, downward transmission rates, and this can be a little bit ad hoc. And that's because we have this compartmental nature, and we assume that you have sort of uniformity or at least homogeneity within each of these compartments. And this is what brought up curve fitting models. And so there's a couple different flavors of curve fitting models, and we'll just talk about some of the more popular ones. So ones that you probably see on the internet, so a lot of them are serial growth models. And so this is really simple. So you figure that the number of new infections is a function of previous infections. And so often it can be weighted by or scaled by the reproductive number. This is the R value you hear so much about, which just simply put is the number of people each infected person goes on to infect. And this is now, we allow it to be time varying because we know that it varies across time. And oftentimes this is also weighted by the amount of time between infection and infecting another person. And then we also have to model deaths, and deaths are often modeled as a second step. And usually we use something like a negative binomial that predicts the number of daily deaths conditional on the recent number of infections. And so it's also important to remember that a lot of these probabilities we're modeling are conditional and not marginal probabilities. Okay, and then we have statistical models. And so here we can actually have a lot of flexibility. And so what you want to do is you want to fit the data that you observe as a function of time and other covariates. And a lot of the popular ones are log linear, ARMA, which is the autoregressive moving average ones, exponential, logistic. And generally, these can accommodate the sigmoidal shape of cumulative counts. And so sigmoidal is sort of that S shape that you see that has an exponential part and then sort of a logarithmic part. And so, so these type of models can account for this pretty easily. And they can also incorporate time varying covariates like mobility data, social media information. And so I know Google and Apple have been tracking mobility, and we can put these into our models. But the caveat is that it's hard to forecast forward trends because they're sort of unknown in the future. We sort of know what they are for the short term, but we don't know how trends may change in the future. And so it could be harder to incorporate information about information on spread if we're only modeling deaths, because we know that deaths lag infections, but deaths give us really more reliable data. So a lot of the models that you see, they're modeling deaths, and IHME is one of them because they're more reliably reported. So every day I track down news stories of cases and testing and problems with the data. And so deaths tend to be much more reliable in a statistical precision way. And we can incorporate all of this information, but they do lag infections. And so what we see is going on in terms of interventions. Then we see later on, we'll see it in infections, and then we'll see it in hospitalizations, and then we'll finally see it in deaths. And so another caveat is we often have to model one outcome at a time. We are modeling infections, we are modeling deaths, and then we need to take additional steps to predict other quantities. Oh goodness. And then machine learning. So neural networks are often used in conjunction with compartmental models. So this beta, this is a parameter that often relates S to I. And so here's two good references where they've done a really nice job incorporating machine learning into these models. And they can also be used for curve fitting. But to our knowledge, we're the only ones that combine all three. Oh, and some other models to be aware of. So there's agent-based models, and what they do is they simulate individuals of a population and how they interact. And so this gives us a really nice mechanism for modeling the effect of interventions. And so you don't have that homogeneity assumptions where everybody in that compartment is the same. But it does require assumptions on human behavior and their interactions within the population, as well as the infectivity of SARS-CoV-2. And this is not a trivial matter. Feynman most famously was commenting on quantum mechanics, and he was saying how much harder his job would be to model the interactions of electrons if they had feelings. And so modeling human behavior is not for the faint of heart. Okay, so let's talk about our model. And so what we wanted to do is we wanted to combine all three of these modeling techniques to get a very flexible model. So we used the SEIR compartmental model, which I talked about before, that's susceptible to infected, recovered, and dead. And then we fit a Bayesian nonlinear mixed model to case velocity, and I'll talk about this in a second. And then we used random forest to be able to model the death rate. And so this is where we used the California Health Interview Survey specifically for California, and we had to use other data sets for other states, but the CHIS data set was absolutely beautiful. And for our very first models, we relied very heavily on it, and also for California. So this is, I swear, this is the only one that has equations on it, and I'll talk about what this means. So this is just for people that want to know what our system of differential equations is. But really, all this is doing is telling us how do people transition from being susceptible to be infected, and whether they recover or they die. Okay, and so we allow these transition functions to vary in time. And then we want to be able to incorporate covariates and other information, as well as uncertainty. So the transition between S and I is determined by this xc of t. And this is, think of it as the number of confirmed COVID-19 cases. And then we transition out of I with a rate parameter, which is the inverse of the number of days a person is expected to be infectious. And transitioning out of I is determined by this death model, which is this theta of t, and this is the random forest. And as a caveat, we only do deaths from COVID. So we ignore births and imported cases. So we're just modeling this system. So if somebody gets hit by a car and it's not due to COVID, we don't count that. Okay, so let's talk about this xc term and how we get from, how we transition from compartments. So what we do is we want to model the velocity of the new cases, because we want to really know the trajectories. And so we look at the log cumulative case counts. And so we look at these, and these are monotonic, so they can never decrease, cumulative can never decrease. But we need a lot of continuity. So we fit a cubic spline to the observed log cumulative case, and then we observe the derivative at the observed time points. And so really what this gives us is the instantaneous rate of new cases. And this is very similar to the reproductive number. And we can estimate this velocity by fitting this cubic spline. And that way we can really see if cases are accelerating, decelerating, or staying same. But you might say, you're like, oh, but this is a cumulative case count. It can never be negative, right? So we employed this log link to map this velocity across the whole real line. And this is where the nonlinear Bayesian mixed model can be used to obtain location-specific estimates of this trajectory. So we can do this even down to the zip code level if we have the data. So currently we do it for counties. Some states actually provide us zip code level data, and we can actually do it by zip code. But we also do it just by state as well. But by doing this, we can actually borrow strength across locations while accommodating for individual variation. And this is where this mixed model comes in, because this allows us to do this in a statistical framework. And all right, and so we do this for 500,000 times, and each of these instances gets put into our model so we can actually get estimates of uncertainty. And so let's just look at what this tells us. And so here, for a couple of states, you can see the log cumulative cases and the velocity. So here are the cumulative cases for a couple states. Here's California, here's New York. And now let's look at the velocities. And you can see that there's a lot of differences in these velocities. And it's also important that we only did this since there were 100 or more confirmed cases, because this is where you have community spread. And now all 50 states have it. So we're able to model every state, and just about, obviously we can't model counties that do not have 100 cases or zip codes that don't, because we don't have community spread, but we can borrow strength across locations and pool those ones to be able to get estimates for this. And you can see that there's a lot of structure to these. Okay, and so we fit this model, this nonlinear Bayesian model, and we get the posterior estimates for these locations, and we can model whether or not they have interventions, what interventions they have if they don't have it. And to incorporate uncertainty, what I was saying before is we run the model separately for each of these 500,000 posterior samples for this CFT, so we can get interval estimates quantifying uncertainty. Okay, and so now we need to transition out of I. So we've gone from S to I, and now we want to figure out how do we get out of I, and we assume that it's an inverse of the expected number of infectious days. And from the literature, they say it's about 14 days, which is why we have the quarantine for 14 days. But we're statisticians, and we never like to say we're certain. We like to incorporate uncertainty. So we sample from a Gaussian with a mean of 14 with a variance 1 to be able to incorporate uncertainty into our estimates. And then the transition to death is determined by random forest, which is a machine learning algorithm that I find is very useful in many applications. It's very fast, and of course we're running 500,000 posterior samples, so we do need to make sure that our stuff scales. And what is really nice about it is that it allows for easy incorporation of covariates, age, sex, race, comorbidities, density, anything that we think is useful can do it. And what's really nice about random forest is unlike traditional linear models, you can actually have more covariates than observations, and it ignores ones that aren't useful for prediction. And so we fuse all of these together so we can incorporate the strengths of 3 different modeling approaches. And like we were saying at the beginning, we really relied heavily on the CHIS data, especially for California, because we live here, we were really interested in modeling California at first. And the CHIS gives really nice representative samples of things like comorbidities, race, gender, that is representative of California as a whole. So we could get really good estimates for, especially for death, because we know that, that patients who are older have comorbidities, and also by sex and by race have differing outcomes in terms of morbidity and mortality. And we wanted to be able to incorporate this into our models. Okay, and so another really nice thing about random forest is it allows you to look at covariate importance, and it really does find what we expected, that age and comorbidities, but also density really matters. So people that are living in dense households have higher risk than those that are sort of alone and maybe a single family home. And so we can look at these and know that it really makes sense across all the data that we're seeing worldwide in our model. And so this is just a mean squared error with the permutation importance and the variables value. And if you have questions, feel free to email me. This is not meant to be a technical talk, but just know that our death model really does make sense with what we're finding across the world. Okay, so now let's talk about predictive accuracy. So I'm going to take a minute to explain what the maze is. And it's just the mean absolute scaled error. I know it sounds like a lot, of the posterior median number of cases and deaths, and we do this separately. And so what we're looking at is a ratio, like our model versus a model where we're just saying that cases or deaths are just a random walk of the training data. So meaning, and you see this, I see a lot of, everybody has a model these days, and I see it on the web where they're just doing predictions based on where you were, maybe the week before. And so this is our baseline the accuracy of a random walk forecast of the training data. So we get to see all the data, and it just predicts, 1, 2, 3, 4 weeks forward. And so a maze of 1 means that we're not doing any better than just a random walk. Less than 1 means we're doing much better. And so here you can sort of see this 1 here. And so when we did this was in early April. And so here it is across time. And especially really close, we're doing much better than a random walk. And for cases, we're at 0.4, and for deaths, 0.32, which is well below 1, suggesting that we have very reliable predictions. Okay, so let's talk about some of the results. And here is California. This is data that was done yesterday. And so this is a really fast-moving epidemic, as you know. And so let me explain what this output is. So this green line is the cumulative cases, not on the log scale, but on the native scale. So this green line with this little shaded region is our, it's like our 95% credible interval, but it's not quite a credible interval because, for the death model, it's not, because random forest is not a probability model, but for here it is. And then, so this is what our model, and each of these data points are actual data, and we plot these after we do our model. So our model is fitting pretty well. So this is the cumulative number of cases in California by time, and we've projected out through August. And this one is active infections, which is different from new infections and different from cumulative infections, because people stay infectious for, on average, 14 days, and they can go on to infect other people. And people that were infectious are now becoming uninfectious. And so this is, in pink, this is what this is. And this is our 95% credible interval of where we expect the number of active infections. And so we don't have any dots to plot here because this is an estimate, and nobody knows the number of active infections. And so these are our estimates. The orange, these is our death. And so our death model, and because it is random forest, it's very jagged because it's, even though it's sort of smooth, it is a discrete step function. And so each of these dots is a data point. And there is a temporal trend in when cases are reported, and also deaths, with fewer deaths being reported on weekends, and then after the weekend and holidays, we see an increase in deaths, and which is why it sort of goes like this. And so a little happy note, and I really, fingers crossed, hope that it stays true, is for our projections each day, our number of deaths projected forward is starting to slightly decrease. So hopefully California, we won't see high levels of deaths like we saw in New York, but deaths do lag infections, and we are waiting to see what happened after 4th of July. And this last one is RT. So this is this R value, and we allow it to move across time. And so this was early in effect. And so let me explain a little bit about R. So RT, so it changes over time. When R equals 1, that means that the epidemic is stable. For every person that gets infected, they go on to infect one more person. At 1.2, then for every 5 people that get infected, they go on to infect 6. And so this is where we're really starting to worry. At 2 is where we start seeing exponential spread. And so we're hoping that we're going to come down, and we're starting to see signs that that the RT is decreasing in California, but not quite going below 1. So we're obviously watching this every day. Okay, Arizona, this is where I'm from and my family's from, so I worry about it. And so there's actual good news coming from Arizona. What looks like their cases are, hopefully it stays this way, are peaking and starting to decrease. And we're also seeing this in deaths. So, but it's a really wide interval. So it really depends on people really coming together, well, coming together by staying apart, because you can see that the predicted RT is still well above 1. But I'm really hoping that the death rate stays low. But in terms of new cases, it actually looks like they may be peaking, but that assumes that what's happening continues to stay that way. But some actual bit of good news that has been developing this week. New York is looking really good. They were hit really, really hard, and but looks like their death rate is not increasing. They did have a little bump up in transmission here, probably from Memorial Day and all the activities afterwards, but it looks like they are well under control. Georgia, not as much, but we are expecting an increase in deaths, but not as big of an increase that we were seeing maybe a week ago. So if I tend to be an optimist and try and look at the happier side. Florida, we can see that we're expecting a massive increase in deaths there, and really high levels of transmission. Michigan's looking like it was above, but maybe we're not going to see as large increases in deaths. Minnesota as well. And so another caveat, so a lot of people use these online tools, which I think are great, and I'm really happy people are doing that, but you really need to, well, I'm a statistician, so I always like to look at the data. And when North Carolina, at the beginning of June, it was really different from what we were finding in North Carolina. And so what I wanted to do is plot what they were predicting, and this is theirs here in red, versus what our model was predicting, and overlay the actual new cases. And so they were predicting that they were okay, that their spread was not increasing, and that was the opposite of what our model was finding. And so always look at the data. I don't trust anybody else's analysis. I always want the data and to do it myself. Okay, so we combined 3 models so we can get more accurate predictions of cases and deaths. It's very flexible, and we hope to be able to help policymakers make informed decisions with this. And here is the paper, and I'm happy to send it to anyone if they want more information. And these are the 2 papers that I referenced in the talk, and I'm happy to take any questions.
Good afternoon, everyone. My name is Tiffany Lopes, and I'm the Director of Communications here at the UCLA Center for Health Policy Research. We're going to be going through questions from the audience today. I encourage you to continue to use the Q&A function in Zoom to ask questions. We've got a lot of great questions to get through, so let's begin with the first question. How do we know that recovery or death are the only outcomes? And is it possible to continue having this virus in some form, and should that be in a model, if so?
Yeah, so our models are very flexible, and we can model many different outcomes for which we have data. And so where we actually have data are cases and deaths. And so this is what are on the state dashboards. Hospitalization data is coming. It has not been as reliable as we would hope, because we can easily model hospitals. And so with any infection, you either recover or you die. So we just put it in these sort of dichotomous terms, but there is a whole host of things that can be modeled in between. We just need the data to be able to get good models on this. And I'm hoping that the hospitalization data will become really good, and that'd be something. We do model it now, but just separately in different states for which we have good hospitalization data. But it is an excellent question. And yeah, we are really sort of limited on the data, but we do that, and our models do allow for hospitalization data.
Thank you. What data sources are best for this type of modeling? And do you believe that the shifting of COVID data from the CDC to a database more overseen by the presidential administration will affect our ability to model COVID accurately?
Well, for most people that I know that are modeling, we're not using the CDC data. Most people that I see, we're using COVID tracking data, which is done by the Atlantic or by the New York Times or by the states themselves. The CDC data tends to be, it lags by at least a week, oftentimes. And for this, and that's just, we need daily data. And so I'm literally waiting for each state each day to upload their new data, and then we take it. So actually, this doesn't affect our model at all because we don't use it. Mm-hmm. So I do find COVID tracking project and also 1.3 acres. So one of our students was one of the Yunhan was part of this, and they do a very good job. And so what a lot of people are doing is they're just scraping each of these state sites for the data, because we are finding data reliability is a massive issue. And it's hard to reconcile the data from different sources. So a lot of people, we do scrape it from different sites. But as for us, we do not use CDC data, so it won't change us.
Got it. How well did your model predict the increased number of cases expected when California and Los Angeles rolled back the stay-at-home orders?
So here, I can, I can show you.
Perfect.
Yeah, because we do have a Bayesian model, and we do see it, and so you can see, yeah, and so yeah, maybe I could have put little arrows for each of these things, and we can actually project out pretty far. But the more you project, the less reliable it is, and but yeah, so we actually sort of see things before. Sort of before it's reported. And so I think our model is really good and gives, especially in this RT, really sort of gives us an idea of where we're going forward. And also the deaths do lag, but it's been actually quite accurate. And you can sort of see with the deaths that it does track really well.
Thank you. Someone is interested in knowing more about how to interpret R values such as 1.2 or 1.5. And aren't those values very concerning, giving rise to growing number of cases? And shouldn't those estimates be relevant to decisions such as whether to open schools?
Yes, and so so countries actually like Germany regularly report the R values, but you know, you need to take the totality of evidence. This epidemic is really complex, and it's really hard to really summarize everything into one number. And so so the easy way to understand R is when it's 1 for every 1 person they infect, 1 more person. So you see this plateau. At 1.2, for every 5 people, 6 people are being infected. And at 2 is where it really becomes exponential. And so 2 people infect 4, 4 people infect 16. And so that's where you really see these uncontrolled dynamics. And we really do think policymakers need to look at everything, including death curves, because what we really need to do is we cannot overwhelm our hospital systems, because if our hospitals fall, then people who are sick can't get treatment, and perhaps these people will die. And when they could have been saved had there been a bed. I mean, fortunately, in New York, that did not happen. That nobody was denied a bed that needed it. Nobody was denied a ventilator, and you know, which thankfully, and our ability to treat COVID has actually gotten better. You know, the treatment's better, and we're seeing this in the death rate. when in New York, the death rate was incredibly high. And we're not seeing, even though we're seeing cases go high, we're not seeing, at least for right now, we're not seeing the death rates get high. And I really think that our wonderful doctors and nurses and scientists have really done a good job in being able to prevent death in COVID. And so that really is good. And we've also learned how to expand hospitals. And I think the hospital system has been absolutely amazing. Opening schools is really sort of tough. And I really do worry about, sort of structural inequalities that really fall on lower socioeconomic parents, especially parents of young kids. If they are more likely to be essential workers, and if they have young kids, do they have to make, I don't even know how you make this decision of, do you send your kids to, do you stay home and watch your kids, or do you go out and work to be able to provide food for them? And I mean, it's a terrible choice, and especially if you are a single parent. And so, so the issues are more than just one number, and they need to be sort of examined in their totality, because we know that COVID has disproportionately impacted communities of color and those of lower socioeconomic status, and closing the schools is going to burden them disproportionately as well. So I really worry about that impact.
Got it. You mentioned earlier about modeling interventions. Could you talk a little bit more about it? And would these be the timing of reopening and universal masking rules? And can you talk a little bit about what you've done as far as masking?
Yeah, so when we started modeling in March, one of the, this was before the governments did any interventions, we were thinking to ourselves, how do we do this? What would be sort of the best practices? And so we looked throughout the literature, and we actually envisioned these interventions at the workplace, because an employer has control over their of their workplace. And one of the things, besides hand sanitization, social distancing, we actually thought of masks as source control, because the employer has every incentive to keep their employees safe, but also their customers safe. If customers don't feel safe, they're not going to go into their establishment. So we actually modeled the first interventions in the workplace, because we didn't have anything in terms of a governmental intervention. And one of the things we really thought about were masks, especially because we were seeing reports of asymptomatic infection. And so if you don't know you're infected, we don't want people to inadvertently transmit. And so we just wanted to figure out a way for people to keep their droplets to themselves. And at this time, masks were really in short supply, and we did not want to take it away from the healthcare workers, because, if healthcare falls, we all fall. And so we're like, scarves, bandana, any sort of facial coverings, so that people keep their droplets to themselves, should be able to slow the spread. And so we could actually model this in terms of transmission, and contact rates. And so we did. And then California was one of the first to enact it. And then we can model it in terms of reduction in transmission. And so because we're doing this Bayesian model, it's just one more covariate that you can put in. I hope that answered your question.
I think so. Could you actually talk a little bit more about how you use time covariates, new cases on T1 and new cases on T2 from slide 21? Let's.
Oh, yes. Okay. So if you're familiar at all with random forest, the way that you have to put in the data. And so we know that, that you have this autocorrelation. And so we allowed this to be part of our X matrix. So X's are your predictors, Y is your outcome. And so, as you can expect, cases today look a lot of cases up to 2 weeks, because we know that people are infectious for about 2 weeks. And so, so yeah, we allowed this to be in our model, even though we know that we have correlation here. We actually have a machine learning algorithm that does take into account incorporation that is an extension of random forest, but we need to, it is rather computationally intensive, and we like to put out this stuff daily. And this already takes overnight to run, because we do 500,000 posterior samples. And so, but actually the, all it really, it doesn't really change the variable importance in this case, because we've done all sorts of testing of what happens under, to variable importance under correlation. And so for this, we are actually getting good variable importance measures for it. And all of our usual suspects do appear. And so we are pretty confident in this. And when we match it to actual data, our death model seems to be doing a good job predicting.
Got it. Were you able to determine a range of lag time between an increase in community spread and increased risk of infection?
I'm not quite sure I understand that question. And so we do allow the infectious time to vary randomly. And so we can incorporate this measure of uncertainty. But certainly if people were infectious for shorter periods of time, we would see less community spread. But barring pharmaceutical intervention, I don't really see that as happening, unless you, of course, lock down and you take those people out of circulation.
Got it. How far does the model predict the infection and death rates? Is it 3 months ahead or longer?
We can put it out until we run out of susceptibles, because it is a compartmental model. But of course, as with anything, the further you project out, the higher or the larger the credible intervals. And so usually we project out about 4 weeks, but we can, there is no theoretical stopping, limitation other than if we run out of people.
Okay. Does your model help to better quantify the percentage of persons who have asymptomatic versus symptomatic infection?
No, we would need really good testing and testing data to be able to do that. So the data that we get are on cases that have been identified and people that die. And so we are really data driven, because we're statisticians. And so if we had really, Iceland has had some fantastic studies on transmission, because they have done some widespread testing. So we are reliant on the data, but that is a fantastic question, and one that is really important. And as we are seeing more testing, we are seeing a lot more asymptomatic spread.
Someone mentions that they recently read that the virus is mutating regularly and that newer strains are less lethal. Can your model adjust for the changing death rate and help understand the different strains of the virus?
Okay, so it's the mutation. Yeah, so it actually has not been shown that there is, the papers are saying that they believe there's increased ability to infect, so increased infectivity, but they haven't seen a change in pathogenesis. So it doesn't look like it's more lethal, but it also doesn't seem like it's less lethal. So, but yeah, our model could take into account, I mean, Betty Korber's paper is really sort of brilliant, where it's showing sort of the coevolution of these two strains and one of them becoming dominant. But I've not read any papers that show that it has any impact on the pathogenesis of the virus. But I do look at the literature every day. It's what I do. But I haven't seen any papers that suggest changes in lethality.
Got it.
But yeah, our model could easily incorporate that if we know, if we are actually sequencing the virus and we know which strain somebody is infected with, which is another thing that Iceland is doing, which is really sort of interesting, because then you can really see where the virus was imported.
Got it. Does your model account for heterogeneity in the number of infections caused by any infected individual?
Yes, it does. So, so this is why we have this 500,000 posterior samples from that XC of T. And so for each of these samples, we're running a model. So we have 500,000 realizations of this model. So it does incorporate a lot of this heterogeneity. And we also incorporate, allow the infectious time to vary randomly as well, to be able to incorporate, you know, this uncertainty, because statistics is never having to say you're certain. And really, point estimates really don't help inform policy making, because it gives you too much confidence in that. You have to have sort of this confidence interval or credible interval around it. And because this does incorporate this uncertainty, because different people have different courses of infections. For some people, it affects them terribly, and for some people, they're asymptomatic, but we also have these super spreading events. And so we need to be able to incorporate this uncertainty into our models.
Great. We have some questions about the modeling and the methods that are more technical actually for you. So what was the fitting procedure you used for this model, and what methods did you use to get uncertainty estimates? Additionally, could you also talk about how fusing the ML model helped over a baseline of vanilla SIRD?
Yes, and so so if you look at the vanilla SIRD, it really overestimated the number of infections and the number of deaths, because it didn't take into account that it really was, that there was this disproportionate impact by age, that it didn't kill people sort of equally. And so a regular SEIR model, you have to, it's governed by this dynamic equation, and you can't really, doesn't naturally fit these covariates. And so we did our model in R, and we used good sampling. And so we did a burn-in of about 100,000, and we kept 500,000 posterior samples of our good sampler. And so for each of these samples, we run through this SEIR model. So it goes through this model and goes to the death model, and we get one instance of our output. And we do this 500,000 times to get estimates of uncertainty.
Got it. And somebody's interested in knowing sort of the secret sauce, your software, and are you sharing any of your algorithms?
Oh yeah, absolutely. It is on GitHub. It's if you get the paper, you can replicate everything. It's all done in R. Well, I use RStudio, but yeah, so we do make our code available, and our methods are explained in detail in our paper, which is available as a preprint. It is under revision for PLOS computational biology. And yeah, and we are happy to share.
Thank you. We've got time only for a few more questions, and there are a lot of questions in the queue. So to anybody who hasn't had their questions answered, don't worry, we will get to them after. But let's get to a couple before we have to close up. The first derivative rate of case velocity was said to be similar to the reproductive number, but looking at the graph, many of the values were below 1. Is there a way to map first derivative to actual R0?
An excellent question. We really didn't do that, but remember yeah, so we can map. So you're talking about this one, and this is not, it's not a one-to-one mapping where it's on the same scale from pretty much 0 to infinity. And so, so it's not quite on the same scale, but it's really sort of similar, because that R value is really sort of showing, is your epidemic increasing, decreasing, plateauing, and the velocity is getting at that same thing. And so velocity doesn't quite have that, if you have X people infected, they go on to infect somebody else. But the R comes with its own sort of assumptions. And so we just really wanted to take the cases and see what the velocity is. And to be able to do this naturally in the data that we were given, but in this framework that we can add covariates.
Got it. If you run your model out to its endpoint of no susceptibles left, what is your current estimate as to total number of deaths that would occur in the USA?
Oh, an excellent question. I actually have not done that, but that would be really interesting. But like I said, our technology increases, our ability to treat increases. So I actually really have faith in our medical community and our scientific community that even if our cases keep going up and everybody gets susceptible, that or gets infected, that our medical ability will be able to save a lot of these people that may have died had they been infected earlier in the epidemic. And but I also hope everybody doesn't get infected. But so no, I have not done that.
This is a really interesting question. Is it possible to include housing density into your models to account for vulnerable populations increasing, having to move in together due to loss of employment in service sectors as attempted mitigation of homelessness?
Absolutely, and that is one of the things that we incorporated, this this population, this density. And so because there we just did simple for states, you know, just sort of the average density. So knowing that New York City is much more dense than, you know, Wichita Falls, you know, and so we wanted to be able to incorporate that, you know, but it's an absolutely brilliant question, and we see this when we are looking at different counties and actually different locations around Los Angeles County, that places that are hit harder are ones that are much more dense or have a higher proportion of multifamily living arrangements, because you just have that much more contact between people. And, you know, places that have mass use of subways, you know, anywhere you see a lot of people congregated together, these give chances for this virus to infect other people. And so, yeah, absolutely. So we put it in with our death model, but we could actually incorporate it in our mixed model as well.
Are there any policymakers that you're working with, or are there any policymakers that are using your models, and which policies have been informed by your models?
So early on, we were talking with Mayor Garcetti's office to use masks, and Mayor of London, and also some people in South Africa. Mainly right now, we are working with businesses to help them open safely, and how to protect their workers. And but we're happy to help anybody that wants our help.
Thank you. Unfortunately, those are all the questions we have time for this afternoon. If we didn't get to your question, please email us at healthpolicy@ucla.edu, and we will get back to you. I just wanted to thank you all for attending this month's webinar on combining traditional modeling with machine learning for predicting COVID-19. And a big thank you to Dr. Christina Ramirez for presenting this very timely study. We will be posting the recording of this webinar online with closed captions within the next 2 weeks. So visit healthpolicy.ucla.edu. As a reminder, if you'd like a copy of today's presentation, you can also email us at healthpolicy@ucla.edu. And stay tuned for details on our next webinar in August, featuring the students and activities of the Native Hawaiian Pacific Islander COVID-19 Race Tracker Lab, happening right here at the Center for Health Policy Research. Have a wonderful rest of the day. Thank you.